It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Review. Today we're going to talk about Meralgia Paresthetica. Before we get into that, check out NRAPpain.org where we have ultrasound training, regenerative medicine training, and much more, as well as a large question bank for the Pain Management Board that covers the ABA, ABPM, FIPP, osteopathic, and more. So check it out for CME credits. And now Meralgia Paresthetica. So Meralgia Paresthetica is a mononeuropathy of the lateral femoral cutaneous nerve. It's a sensory nerve, not a motor nerve, and it covers the anterior lateral thigh. It results from entrapment or compression of the nerve as it passes under the inguinal ligament near the anterior superior iliac spine. Board pearls include the fact that this nerve is purely sensory, there will be no motor weakness, and that it covers the anterior lateral thigh. Keep in mind there's also an anterior cutaneous division of the nerve which covers the anterior thigh down to the knee. The lateral femoral cutaneous nerve originates from L2-3 of the lumbar plexus. It travels across the iliacus muscle, passes under or through the inguinal ligament just medial to the ASIS, and enters the thigh. Compression can occur most commonly from obesity, tight belts or clothing, pregnancy, prolonged sitting, diabetes, and prior pelvic or hip surgery. It's the most common site of entrapment at the ASIS medially and under the inguinal ligament. Patients will describe burning, pain, tingling, numbness, dysesthesia. The pain is localized to the anterior lateral thigh. There will be no motor weakness, no reflex changes, and the pain will be worse standing or walking. Relief can occur with hip flexion or sitting. Diagnosis is clinical. There may be a tunnels over the inguinal ligament producing the symptoms. EMG and nerve conduction studies will be normal, and ultrasound can visualize the nerve entrapment. Of note, this is a superficial nerve. It's usually quite easy to see on ultrasound, even in the obese patient. First-line therapy is weight loss, avoid tight clothing or belts, physical therapy, non-steroidal anti-inflammatories for inflammation. Medications may include the neuropathic pain medications such as the gabapentin and pregabalin, or the gabapentinoids, duloxetine, and tricyclic antidepressants. On a personal note, I would add to that you could consider a topical analgesic cream as well, such as lidocaine or anti-inflammatory or other combination cream. If conservative medication fails or conservative therapy fails, image-guided intervention is highly effective. Personally, I strongly recommend ultrasound, not fluoroscopy, as this is an easy nerve to visualize on ultrasound. It lies lateral to the sartorius muscle and can be localized. You could even see the nerve as it branches out into its different divisions or separates from the anterior cutaneous nerve of the thigh or femoral nerve. With ultrasound, you could allow real-time injection. I've come across patients who have had multiple procedures prior to meeting me under the blind approach or fluoroscopic approach, and they've had more pain after the procedures. My guess is the nerve was traumatized further from an approach that does not clearly visualize the nerve as ultrasound does. So I strongly recommend anyone doing this procedure to use ultrasound and not fluoroscopy, and to avoid the blind approach as well. Surgery is rarely required, but may include neurolysis, decompression, or neurectomy as a last resort. The boards love to ask which nerve is involved, which, as I mentioned earlier, is the lateral femoral cutaneous nerve. The pain boards will also ask which nerve roots are involved. It's typically L2-3, but there are variants across the population. The boards will ask, the pain boards will ask, is it a motor or sensory nerve? Know that it's a sensory nerve. The compression site, which is under the inguinal ligament near the ASIS, no motor weakness. It's a first-line therapy, is conservative care, and refractory patients will undergo ultrasound-guided nerve block. I would say refractory patients, or just patients who are suffering so much, it can be quite painful. I definitely did not appreciate how painful this disorder could be when I was learning this for the boards, but in my practice, I've seen patients whose lives were practically ruined by this disorder. So know the anatomy, and a few personal notes with this disorder. I've used peripheral neuromodulation for this problem, and it's helped somewhat. I've also used cryoablation. I've definitely seen some benefits to cryoablation for the lateral femocutaneous nerve in the treatment of Meralgia Paresthetica. Target keywords to know are Meralgia Paresthetica, lateral femocutaneous nerve, or some people will call this lateral cutaneous nerve of the thigh, but more commonly it's the lateral femocutaneous nerve. This can appear on your ABA, ABPM, ABIPP, FIPP pain boards. It's important for your pain practice. If you're a patient and you're looking for care of this disorder, you could come find me and make an appointment in my Brooklyn office. And I think it's underappreciated how painful and disabling this disorder is, and it's pretty much guaranteed to appear on your pain boards. So know it. It's quite a useful nerve block to know how to do if you're not doing them, and if you're not trained interventionally, I suggest you refer the patient to an interventionalist who can help alleviate or diagnose the disorder in your patients.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.